is congestive heart failure? You may get the question as congestive heart failure or heart failure. Congestive heart failure is the old outdated term. We don't use the term congestive heart failure anymore. Why we don't use this term, we'll get to know shortly. So if we get the question as heart failure or congestive heart failure, anything, this is the answer that we should write. So let's go on to definition of heart failure. What is heart failure? Heart failure or cardiac failure is a pathophysiological process in which heart as a pump is unable to meet the metabolic requirements of the tissue for oxygen and substrates. Despite the venous return being normal or increased. See, when there is end organ reduced perfusion, it can be due to many reasons. We have discussed the reasons in types of shock. So the venous return is decreased in case of hemorrhagic shock, etc., distributive shock, etc., etc. If the venous return is adequate and the systemic circulation is not getting adequate blood, means there is problem in the pump. So due to inadequate contraction of heart muscles, there is a reduced oxygen and nutrition supply or substrate supply to the tissue and cells of the body. This is the definition of heart failure. Now, there are broadly two kinds of heart failure. That is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. You may ask me, what about heart failure with low output heart failure, high output heart failure, systolic dysfunction, diastolic dysfunction, right heart failure, left heart failure? All these terms are not used nowadays. Only two broad classification is present currently, that is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. The definition, I mentioned that, sorry, before definition, while introducing the term for you, I mentioned that the congestive heart failure term is not used anymore. Why? Because we can have heart failure with preserved ejection fraction, and also we can have heart failure without any symptoms of backward blood flow, causing backward symptoms like congestion in the liver, spleen, etc., etc., etc. So broadly we'll tell heart failure. So I told you that heart failure is of two types: heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. What is heart failure with reduced and preserved ejection fraction? On echo, if the ejection fraction is less than 40%, it's called heart failure with reduced ejection fraction, which is the most common type. And we are happy. Among these two, it is better to have heart failure with reduced ejection fraction than heart failure with preserved ejection fraction, because we have medical treatment for heart failure with reduced ejection fraction, but we have not found any drugs which are effective in heart failure with preserved ejection fraction. So in case of heart failure with preserved ejection fraction, the ejection fraction will be more than 50%. Let's continue. First, we will discuss heart failure with reduced ejection fraction, then heart failure with preserved ejection fraction. In the answer, we need to elaborate more on heart failure with reduced ejection fraction. This is what the examiner will expect us to answer. Before going to it, let me briefly explain heart failure with preserved ejection fraction. It is not asked in RGSH exams, but I'll mention it briefly for your understanding. What is the pathophysiology of heart failure with preserved ejection fraction? It is most commonly seen in the patients who has comorbidities like obstructive sleep apnea, diabetes, hypertension, and chronic kidney disease. Now, what these comorbidities lead on to? These comorbidities will lead on to the inflammation of microscopic vessels inside the myocardium. Please note, it's not the inflammation of coronary vessels, which are the big arteries. It's the inflammation of microvascular structures. The microvascular inflammation causing interstitial fibrosis. When there is microvascular inflammation, inflammation is followed by fibrosis. So causing interstitial fibrosis and also reduced ATP. And due to this reason, when there is interstitial fibrosis, it causes impaired relaxation of left ventricle and right ventricle. What does impaired relaxation of left ventricle and right ventricle cause? In order, there is a golden rule in cardiology, that is, in order for heart to contract adequately, it should first relax adequately. Please note this point. So when there is impaired relaxation, it leads on to increase in left atrial pressure. Why it increases left atrial pressure? Here left ventricle is not relaxing properly. There will be back pressure into the left atrium, leading on to increased left atrial pressure. And what is the sequelae of it, we'll see shortly. Increased left atrial pressure causes stretching of this left atrium. Stretching of this left atrium will induce atrial fibrillation. So it may lead on to death in few patients. This is in brief about the idiopathogenesis of heart failure with preserved ejection fraction. The comorbidities are obstructive sleep apnea, diabetes, hypertension, CKD, leaning on to microvascular inflammation, interstitial fibrosis, leading on to impaired relaxation of left ventricle, which causes increased left atrial pressure, and due to stretch of the left atrium, there may be atrial fibrillation and leading on to sudden death of the patient. What are the clinical manifestations seen in the patient? Due to increase in left ventricular end diastolic pressure, I'll come to it later. There is atrial fibrillation due to this cause, and then there can be dyspnea due to pulmonary edema, and there can be right heart failure. We'll touch on these points. So briefly, you remember these points about heart failure with preserved ejection fraction. Next, we are going on to the most important thing, that is heart failure with reduced ejection fraction. Let's see etiopathogenesis first. What is the etiology of heart failure? Why does the pump is not performing its activity well? It may be due to two kinds of diseases, due to congenital heart diseases and some diseases which are seen in adults. Congenital heart diseases like tetralogy of Fallot, VSD, ventricular septal defect, and then not atrial septal defect, which is not commonly associated, transposition of great artery, etc., etc. All these congenital heart diseases, which will be discussed in detail in pediatrics, will lead on to heart failure with reduced ejection fraction. What are the causes in adults? In heart, we have myocardium, which is responsible for pumping, and also we have valves, gatekeepers. So when there is disease process involving these gatekeepers, valves, or involving this myocardium, it leads on to heart failure. What are the most common disease which involves myocardium? That is ischemic heart disease. And the diseases involving valves which lead on to heart failure are severe aortic regurgitation, severe aortic stenosis, and severe MR, that is mitral regurgitation, not MS. Please note, these three diseases are associated with heart failure with reduced ejection fraction. MS is not commonly associated with heart failure with reduced ejection fraction. We'll discuss about it when we discuss MS tomorrow. So I talked about etiology. Etiology can be congenital heart diseases and adult onset diseases like ischemic heart disease, severe aortic regurgitation, severe aortic stenosis, aortic stenosis, and then severe MR, that is mitral regurgitation. This is about the etiology. What are the pathological processes occurring in the body which leads on to the symptoms that we see in the patient? So We know now the pump is failing. It's not performing its function adequately. When the pump is failing and it's not performing its function adequately, it leads on to decreased systemic perfusion, and also the blood which is pooled here, which is in the left atrium, will cause back pressure, leading on to pulmonary symptoms. And with the time, this causes pulmonary hypertension. This pulmonary hypertension with time will cause right heart failure, and this will in turn cause back pressure and congestive heart failure. So this is a story. When there is left ventricular failure, it causes back pressure, increased left atrial pressure. This causes back pressure in the pulmonary system, which causes pulmonary edema, pulmonary hypertension and all. Pulmonary hypertension occurs in long run. And then this pulmonary hypertension will eventually leads on to right heart failure, which is called as cor pulmonale. And then this right heart failure will lead on to back pressure and congestive heart failure. Now, what are the, due to this reduced systemic perfusion, we know the baroreceptors are sitting in the aorta and in the vessels, the carotid vessels. The stimulation of baroreceptors will cause activation of sympathetic nervous system. And also when there is reduced systemic perfusion, the renal blood supply is reduced. When there is reduced renal blood supply, reduced blood supply in the afferent arteriole, it causes by myogenic response. It causes really activation of RAS system. Now I mentioned that due to reduced systemic perfusion, two things are occurring. That is sympathetic activation and reduced renal blood supply, leading on to myogenic response and RAS activation. And also there is forward failure, which we will discuss now. Due to increased sympathetic activity, there will be tachycardia seen in case of heart failure patient. Sympathetic activity leads on to tachycardia. And also the sympathetic activity, the stimulation of beta receptors in the cardia, in the myocardium, will cause cardiac remodeling. The cardiac remodeling, initially it helps. Why it helps? Because now the heart is becoming thick, stronger. But with time, when there is increased thickness of myocardium, there is reduced volume inside the left ventricle, leading on to diastolic failure. There is impaired filling of heart. So with time, it worsens the matter. So giving beta blockers in this patient is associated with better prognosis, reduced morbidity and mortality. And then there is RAS system activation. This RAS system activation will lead on to increased aldosterone, angiotensin 2 levels, which causes systemic vasoconstriction, increased aldosterone level, which causes fluid retention. And then we have activation of ADH, release of ADH, antidiuretic hormone, leading on to hyponatremia. Why hyponatremia? When there is ADH release, antidiuretic hormone, the body tries to conserve more and more water. Now the body is thinking, since the heart is not pumping, let's increase the preload by increasing the volume of blood, by activating RAS system and releasing ADH. Why? So there is increased water inside the body. This increased water content will cause dilutional hyponatremia. dilution, hyponatremia. So these are all the compensatory mechanisms which are occurring in heart. I mentioned there is sympathetic system activation due to baroreceptor activation, which leads on to tachycardia and as well as ADH release. There is a RAS activation due to myogenic response. These lead on to volume expansion due to water retention, water and solute retention. More common, mostly water retention due to ADH release. This is about the compensatory mechanisms, etiology. Now let's see, due to reduced cardiac output, why the patient is developing the particular symptoms that we see in heart failure. Due to reduced cardiac output, there is reduced pumping of blood. Reduced pumping. Reduced pumping will obviously cause cyanosis, impaired mentation due to reduced blood supply to the brain, cool extremities, reduced urine output due to reduced blood supply to the kidney, and also in the long run, cachexia and fatigue due to TNF alpha release. So these are all the forward symptoms that we see in heart failure. What are the backward symptoms that we see? What's the meaning of backward symptoms? The backward symptoms are due to increased left ventricular pressure. I told there is increased left atrial pressure leading on to back pressure into the pulmonary system. This will cause dyspnea, the characteristic paroxysmal nocturnal dyspnea and orthopnea, which is mentioned in this question. And also there can be pleural effusion and right heart failure eventually, which I explained, that is cor pulmonale. This is about the etiopathogenesis of heart failure. I'll summarize it once again. The etiology seen in children and adults, I mentioned. The pathophysiology, how the heart fails. Left ventricular failure leading on to increased left atrial pressure leading on to back pressure, pulmonary symptoms, pulmonary hypertension, right heart failure. The pulmonary disease causing right heart failure is called cor pulmonale, and which eventually causes back pressure and leads on to congestive heart failure. What are the compensatory mechanisms that are seen? That is sympathetic activation leading on to ADH release and also tachycardia. There is RAS activation leading on to salt and water retention and vasoconstriction, systemic vasoconstriction. There is a reduced cardiac output. Why we see forward and backward symptoms we saw? The forward symptoms are the cyanosis, impaired mentation, cool extremities, reduced urine output, cachexia and fatigue due to reduced systemic perfusion. The backward symptoms, dyspnea, pleural effusion and right heart failure due to this reason. This is in brief, not in brief, extensive about etiopathogenesis of heart failure with. So this is about etiopathophysiology of heart failure with reduced ejection fraction. What are the clinical manifestations? The symptoms I already mentioned, most of the symptoms. The reduced, I'll 1 minute, give me 1 minute. The symptoms seen in heart failure. Manifestations we are talking, symptoms and signs. What are the symptoms seen? Dyspnea, reason we know. Why dyspnea? We can see exertional dyspnea. We can see orthopnea. We can see paroxysmal nocturnal dyspnea. Also, the pulmonary system, its heart failure may be associated with acute pulmonary edema, which we'll talk about in few seconds. That is acute decompensated heart failure. We'll talk about it afterwards. And then there can be nocturia. Why nocturia? The nocturia is observed during only early heart failure. It is because of renal perfusion and diuresis. It's better at night when the patient is supine. I hope you understood why there is nocturia in early heart failure. When the patient sleeps, there is better renal perfusion. And also, when there is better renal perfusion, it leads on to diuresis. This causes nocturia. due to increased, that is better renal function in when the patient sleeps. There can be diuresis leading on to nocturia. The cerebral symptoms include confusion, difficulty in concentration, impaired memory, headache, insomnia, and anxiety. I mentioned it here. Forward symptom: impaired mentation. There can be anxiety, headache, insomnia, impaired memory, etc., etc. These are all the specific symptoms that we see in failure. Now we talked about specific symptoms that we see in heart failure, that is dyspnea. In dyspnea, we have exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. And we can have nocturia due to better renal function during night time, and also CNS manifestation like impaired memory, anxiety, etc. What are the non-specific symptoms that are seen? Non-specific symptoms. It includes fatigue, low-grade fever due to reduced cutaneous blood flow, anorexia, nausea, abdominal fullness, etc., etc. I explained why we see fatigue and cachexia due to increased TNF alpha secondary to reduced systemic blood supply. This is about the symptoms that we see in heart failure. What are the signs that we see in heart failure? We have dependent or cardiac edema, most important one. Edema. When we do general physical examination, doing vitals, while checking vitals, we can see increased pulse rate, tachycardia. After that, when we check for pickle, we see cardiac edema or dependent edema. Due to gravity, the fluid accumulates over dependent parts of body. In ambulant patient, it is found symmetrically in both legs, particularly in pre-tibial region and around the ankle. It is less in the morning and become more prominent towards the evening. It is quite intuitive. In bedridden patients, it's seen in sacral region. And also in case of advanced heart failure patients, we can see anasarca. What I told now? Dependent edema. Why dependent edema? See here. Backward symptoms. When there is heart failure, leading on to this backward symptoms, congestive heart failure, it leads on to dependent edema. In case of ambulatory patients, there is edema in pretibial region and around ankle. In case of patients who are bedridden, sacral edema is seen. Now, what the pulse rate? It's increased, but in severe heart disease, it may be decreased. You can see pulsus alterans, which we'll discuss what is pulsus alterans when we discuss 3 marks questions. And then there can be reduced pulse pressure or blood pressure due to reduced stroke volume. Occasionally, there may be mild elevation of diastolic blood pressure due to generalized vasoconstriction. I already mentioned this. BP, what happens to BP? BP may be reduced due to reduced stroke volume, or occasionally due to generalized vasoconstriction due to RAS activation, there may be increased diastolic blood pressure. What happens to JVP when there is right heart failure? Obviously, it will be increased. We are going for cardiology, that's cardiac examination of precordium, that we see elevated JVP. And also when we auscultate the patient, we can see characteristically third heart sound. Third heart sound is due to sudden rapid filling of left ventricle, or the filling of left ventricle against the incompletely evacuated left ventricle. The mechanism why third heart sound is seen is not so important. Just we can remember that we see third heart sound in case of heart failure, and also we can see fourth heart sound also. More commonly, third heart sound. What happens in respiratory system RS examination? In case of RS examination, we see dull percussion notes over the base of lungs. And also on auscultation, we can see crepitations. Why crepitations? Due to backward symptoms leading on to pulmonary edema, etc. So this is, I discussed clinical manifestations now. We have symptoms and signs. Symptoms are dyspnea, nocturia, and impaired mentation. Under dyspnea, we have exertional orthopnea and PND, nocturia, and then CNS manifestations. Not, we should not say CNS manifestation, mild impaired mentation, we can say. And in science, we saw in general physical examination, we see dependent edema. The BP, it can be reduced, or diastolic blood pressure is occasionally increased due to generalized systemic vasoconstriction. Precordium increased JVP, auscultation, third and fourth heart sound. When we do RS examination, we can see crepitations. This is about the clinical manifestations that we see in heart failure. Let's go on for investigation in heart failure. Heart failure investigations. First, we can do chest X-ray. It may reveal cardiomegaly. Cardiomegaly may be due to many causes. It may be secondary to TOF, where there is left ventricular hypertrophy, or it may be secondary to any other disease. Also, we can also see haziness, hazy opacifications on chest X-ray. The reason for which we know. We can also see pleural effusion due to back pressure, backward symptoms. Then we do ECG. ECG may reveal previous MI. How to detect previous MI on ECG? We'll discuss when we discuss the entrance questions next year. This is not important for university exams. So on ECG, there can be ischemia, ventricular hypertrophy. We see ventricular hypertrophy, left ventricular hypertrophy most commonly in case of hypertension, leading on to diastolic heart failure, which we'll discuss again when we discuss about hypertension. Also, we can see the manifestations of arrhythmia. In heart failure, we can see arrhythmia, atrial fibrillation, ventricular, most commonly atrial fibrillation, and we can also see other types of arrhythmia, which can be kept up on ECG. On echo, we'll get to know ejection fraction or any valvular diseases. And then we can also do stress echocardiography. Very, very important, stress echocardiography. In most of the diabetic patients, this is I'm going slightly out of the topic to explain this point because it's very important. In most of the diabetic patients, there may be silent atherosclerotic plaque sitting in the coronary circulation, leading on to the reduced blood supply to the myocardium. These patients may have normal normal ECG findings, but when we give stress like treadmill test and all, when we ask the patient to walk or run or jog, then the systemic requirement of blood increases. There is increase in demand which can't be met by this impaired heart. This will give ECG changes. So if you see your any relatives or someone who is having diabetes mellitus for more than 10 to 15 years or so, they may have, most probably they may have atherosclerotic plaque, which will not be picked up in normal ECG or echo. We can't pick up, only leave it. Only we can see reduced ejection fraction and other things, hypertrophy and all. So doing treadmill test or stress test is very important in this subset of patient. Okay. What is the next manifestation that we can do? We can do, if on ECG and echo, if we are suspecting ischemic heart disease due to coronary artery disease, or if we are suspecting coronary artery disease, we can do coronary angiography. We will detect the block inside the blood vessels. And also blood tests, some blood investigations we can do, like brain natriuretic peptide, which will be increased. and other blood tests like serum urea, creatinine, electrolytes, cardiac enzymes in acute heart failure, and liver function tests, etc., can be done, which we all know. This is about investigations that we see in that we do in heart failure. What are the investigations? Chest X-ray, cardiomegaly, hazy opacification, pleural effusion, ECG findings, ECG findings may be helpful to detect previous MI. The ventricular, what is this? And then arrhythmia and left ventricular hypertrophy. Left ventricular hypertrophy. And we discussed most importantly about stress test, which should be done, and it helps to pick up the silent myocardial infarction. And also we can do echo, where we will see whether the ejection fraction is reduced or not. We can detect valvular heart disease. And these two, if we find that the patient has coronary artery disease, we can go on to do coronary angiography. And then on blood investigations, we can do brain natriuretic peptide, serum, urea, creatinine, the other electrolyte estimation, etc., etc. This is about investigations in case of heart failure. Now let's quickly go on to treatment of heart failure. What is the treatment of heart failure? What is the primary logic behind the treating the heart failure patient? By blocking sympathetic pathway, I already explained that we are reducing left ventricular hypertrophy, cardiac remodeling, which is associated with better morbidity and mortality. We will also block RAS system. We saw that the RAS and sympathetic activation and ADH increase, it trying to cause water retention, thinking that it may help. The body causes water retention thinking that it may help, but actually it's not helping, because the increased, already the myocardium is impaired, so it can't handle if the water content inside the body increases. So we should block RAS system. And also degradation of natriuretic peptide, neprisil inhibitor can be used. What is the pharmacotherapy in case of heart failure? We have beta blockers. Beta blockers block sympathetic system. Commonly used drugs are metoprolol, bisoprolol, and carvedilol. And also we have ACE-ARB inhibitors. This, any drug from these group are effective class effect. The commonly used drugs are ramipril and perindopril. Ramipril and perindopril. The ACE inhibitors are more preferred than ARB inhibitors, because ACE inhibitors increases bradykinin, which causes vasodilation. And also we have angiotensin receptor block. We can use the combination of angiotensin receptor blocker ARB and neprilysin inhibitor, that is sacubitril. Sacubitril helping degrading natriuretic peptides. This prevents degradation of angiotensin 2. Sorry, not degradation, it's action of angiotensin 2, thereby helping in treatment of heart failure. The primary management of all heart failure patient is give angiotensin receptor blocker and neprilysin inhibitor with beta blocker. We'll give all three drugs: beta blockers, ARBs, and neprilysin inhibitor, sacubitril. The natriuretic peptide, ANP, BNP, all these things will live all these things. Please remember about Fantastic Four, the ARNIs, beta blockers, aldosterone agonist like finrinone, and SGLT2 inhibitors, dapagliflozin and empagliflozin. Dapagliflozin and empagliflozin is nowadays picking up the popularity because of its effect in preventing diabetic nephropathy, and also the cardiac remodeling and all, and also weight loss, etc., etc. These fantastic four drugs are seen to reduce mortality in patients. Now we have, this is the basic pharmacotherapy that we give if the patient presents you with heart failure, that is beta blockers, ACE/ARB inhibitors, neprilysin inhibitor. Along with that, we can give aldosterone antagonist or SGLT2 inhibitor. Now, if the patient has refractory heart failure, what to do? What is refractory heart failure? The maximum tolerated dose of beta blocker is given, and all the fantastic four drugs is given. Even after giving all this, the heart rate is more than 70 per minute. There is tachycardia. Then we will try ivabradine, which is a funny current inhibitor. We'll see what is funny current inhibitors, its action on SA node and all when we discuss arrhythmia. The side effect is visual disturbance. And after giving fantastic four and ivabradine, if the patient is still symptomatic, it's called as refractory heart failure. Now, what is refractory heart failure? The maximum tolerated of dose of beta blocker, fantastic four is given, ivabradine is given. The patient is still symptomatic. This is called as refractory heart failure. What to do in these patients with refractory heart failure? If the patient has wide QRS, we will consider cardiac resynchronization therapy. That is, and if it's not done, then we can consider cardiac transplant. With normal QRS transplant, normal QRS complex, will give LV assisted devices or implantable cardioverter defibrillator. You will understand about why these things are done. Why, if wide QRS complex is there, we will do cardiac resynchronization. If there is normal QRS, then why we give LV assisted device normal when we discuss arrhythmia. So this is about treatment of heart failure. So I told you, in treatment of heart failure, first we'll start with beta blocker, ACE/ARBs, and then neprilysin inhibitor. And if the patient is not responding, we'll try ivabradine. Still, if the patient is symptomatic, it's called refractory heart failure. We'll do ECG. We'll see whether the QRS complex is wide or normal. Accordingly, we'll do cardiac synchronization or LV assisted devices. This is about heart failure. We have finished heart failure, which is the most important topic. If the patient has heart failure with reduced ejection fraction or heart failure with disturbed ejection fraction, around 80% of them develop acute decompensated heart failure. So normally they have heart failure, on that they have developed acute decompensation. What is the cause of acute decompensated heart failure? It may be increased preload in case of anemia, pregnancy, impaired myocardial contraction secondary to myocardial infarction, increased afterload in case of uncontrolled hypertension, and other causes. Due to the increased preload or increased afterload or impaired function of myocardium, due to increased preload or increased afterload or impaired function of myocardium, the patient may develop acute decompensated heart failure. Let's see the clinical manifestations and how to treat the patient with acute decompensated heart failure. Acute decompensated heart failure risk factor, we saw the acute decompensated is broadly divided into two types. That is mild to moderate acute decompensated heart failure. Don't worry about all these things. We'll see it afterwards. Or let's take all these things together. In the acute decompensation, there can be four things. I told you, when there is back pressure due to increased blood in the pulmonary circulation, in the pulmonary vessels, leading on to back pressure, leading on to increased pulmonary pressures inside the pulmonary vessels. If the left ventricular end diastolic pressure is between 12 to 25 mmHg, it results in mild to moderate acute decompensated heart failure and hypertensive acute decompensated heart failure. If the left ventricular end diastolic pressure is more than 25 mmHg, it can lead on to pulmonary edema and cardiogenic shock. The one with mild to moderate acute decompensated heart failure will present with congestive symptoms and progressive dyspnea. We'll manage them with oral diuretics like torsemide. And also hypertensive acute decompensated heart failure is seen in case of heart failure with preserved ejection fraction and uncontrolled BP. We'll see about pulmonary edema in depth afterwards. It's seen when the left ventricular end diastolic pressure is more than 25 mmHg, and also we can have cardiogenic shock. So what is acute decompensation? On heart failure, we can have acute decompensation if the patient has increased preload, increased afterload, or impaired function of myocardium. It can be of two types, where left ventricular end diastolic volume, end diastolic pressure. We know what is left ventricular end diastolic pressure. If anyone adds doubt with respect to this, they can unmute themselves and ask. If the left ventricular end diastolic pressure is between 12 to 25 mmHg, we have mild to moderate heart failure. It presents with congestive symptoms and progressive dyspnea, managed with diuretics torsemide. If the patient has hypertensive acute decompensated heart failure, those are the patients who has heart failure with preserved ejection fraction and uncontrolled BP. If the LVEDP is more than 25 mmHg, the patient can present with pulmonary edema and cardiogenic shock. This is about acute decompensated heart failure, not related to this question. Next, we are going on for left ventricular heart failure, and we'll discuss about angina pectoris, myocardial infarction, all these things at once. All these three things at once we'll discuss. Let's see what are they. What are they? By this discussion, we'll end today's session. We'll have much more topic to cover tomorrow. Tomorrow we can do 2 to 3 to 4 hours of session from starting from 11 a.m. Today we'll end by discussing about ischemic heart disease, which encompasses all these things. After the discussion, you will be clear about all these three questions. If you have any doubts with respect to answering the questions, I'll clear in the end. Let's go for acute coronary syndrome or ischemic heart disease. What is ischemic heart disease? IHD. How is it related to heart failure that we already discussed? Ischemic heart disease is one of the causes of heart failure. We saw valvular heart disease, congenital heart disease, and other causes heart failure. The ischemic heart failure is one of the cause leading on to heart failure. Now, ischemic heart disease is not a single disease. We have spectrum of disease from ranging from angina pectoris, we can manage with drugs, to acute coronary syndrome. We'll see what it is. Ischemic heart disease is a group of heart disease in which there is an imbalance between myocardial blood supply and oxygen demand, which ischemic heart disease is the leading cause of death in both females and males. Please remember this point. And the definition is self-explanatory. It's the group of disease where there's imbalance between myocardial blood supply, not the systemic blood supply. The blood supply to the myocardium is impaired, meaning the coronary arteries are not supplying adequate blood to the myocardium, and also the oxygen demand, so it will not be matched. What is the etiology of ischemic heart disease? Why we see ischemic heart disease? The main cause of ischemic heart disease is more commonly due to atherosclerosis and its complications. And other rare causes are emboli, blocking the coronary artery, or vasculitis like Takayasu arteritis leading on for ischemic heart disease, and hemorrhagic disorder like sickle cell anemia, sickle cell disease. In case of crisis, there may be blockage of vessels. So Also, due to diminished availability of blood in case of shock, there can be myocardial ischemia leading on to ischemic heart disease, which is less common cause. We will see. So, the most common cause is atherosclerotic heart disease. The pathophysiology of atherosclerosis is extensive. We'll not go through it completely, but partially we'll touch upon it. And the less common causes are emboli, vasculitis, sickle cell disease, etc. What are the risk factors for atherosclerosis? We'll discuss this because it's been asked as 3-mark question, and also while answering 10-mark question, the examiner expects us to answer about this atherosclerosis risk factor. We all know the risk factors of atherosclerosis, that is divided into modifiable risk factors and non-modifiable risk factors. The modifiable risk factors are hyperlipidemia, hypertension, because we can give drugs and we can reduce the hypertension. Cigarette smoking, please remember cigarette smoking. If the patient is on drugs, if the patient is diagnosed with ischemic heart disease, we start him on drugs like beta blockers and RAS inhibitors, ACERV inhibitors, and other drugs. If the patient doesn't quit smoking, then the drugs will not be of any use. Please remember, cigarette smoking is strongly associated with atherosclerosis, and also before starting treatment, please inform the patient to quit cigarette smoking, or else the drugs may not work. The diabetes mellitus, I should have mentioned is first. Diabetes mellitus, it's also lead on to dyslipidemia. Diabetes mellitus, hyperlipidemia, hypertension, cigarette smoking is modified risk factors. What are the non-modifiable risk factors? Age, more than 45 years in case of males, more than 45 years, and in case of females, more than 55 years. And also the gender, males are more commonly affected than female. The family history and the genetic abnormality, like familial hypocholesterolemia, can lead on to these are all the risk factors associated with atherosclerosis. What is the pathogenesis of atherosclerosis? What is the pathogenesis of atherosclerosis? Atherosclerosis, remember, is a progressive inflammatory disorder of arteries characterized by focal deposits of lipid inside the blood vessels. There's focal deposits of lipids inside the blood vessels. This is very important. There is lipid content and all, how it forms and all. We'll see. The atherosclerotic plaque. Oh, we got it. The atherosclerotic plaque risk factors we saw. The plaque is divided into vulnerable plaque and non-vulnerable plaque. The vulnerable plaque is the one which can easily rupture, which is prone for rupture. Plaque, which is prone for rupture, vulnerable one. The non-vulnerable one, the fibrotic cap covering the atherosclerotic plaque is thick, and it will not let the plaque to rupture. Now, what will happen if the plaque ruptures? If the plaque ruptures, the lipid content in this plaque will be exposed to the blood vessel. Exposed to the blood. When the lipid content is exposed to the blood, our immune cells and our coagulation system is ready inside the blood. It will cause rapid thrombosis. So the thrombosis due to plaque rupture, plaque has ruptured now. Now thrombosis has developed. When the thrombosis develops, the thrombosis can completely cover the blood vessel, or it can partially cover the blood vessel. If it completely cover the blood vessel, it leads on to ST elevation, MI. If there is partially, if the thrombi covers the blood vessel, it has ruptured. blood vessel partially, and there is some patency in the vessel, it leads on to non-ST elevation MI. The non-ST elevation MI, where there is partial covering of blood vessel with a thrombi, it is platelet rich, and the complete thrombosis one is fibrin rich. So what are the risk factors which make the plaque vulnerable and non-vulnerable? What makes the plaque vulnerable and non-vulnerable? We usually don't know. Those who those who have non-vulnerable plaque, they are very happy. They live very happily. The plaque will not cause any problem. They will live very happily, and they may die because of other causes. If the plaque ruptures and there is development of thrombi inside the blood vessels leading on to ST elevation and ST non-ST elevation MI, this is called as acute coronary syndrome. And then this is about atherosclerosis plaque and how it is associated with clinical spectrum of disease. We'll see. Here, how it's related to clinical spectrum of disease. We saw the atherosclerotic plaque first is developed due to inflammation due to modifiable and non-modifiable risk factors. The plaque can be vulnerable and non-vulnerable. If the plaque is not ruptured, it is indolent, lying inside the blood vessels. And if it covers more than 70% of the blood vessel, it causes angina. Angina pectoris. And if the vulnerable plaque rupture and there is development of thrombi inside the blood vessel, which lead on to complete or partial block. If there is rupture and thrombi formation, it is acute coronary syndrome, which can be of two types, that is ST elevation MI and non-ST elevation MI. This is about atherosclerosis risk factors, the plaque, and what happens in case of angina pectoris, what happens in case of acute coronary syndrome. Let's proceed further to discuss about angina pectoris and then followed by acute coronary syndrome. So ischemic heart disease, we mentioned it's a spectrum of disease ranging from angina pectoris and acute coronary syndrome. In angina pectoris, we have a plaque blocking the blood vessel more than 70%, causing symptoms. And in case of acute coronary syndrome, the plaque has ruptured and there is development of thrombi inside the blood vessel. Coming on to angina pectoris. In angina pectoris, we have three types, that is chronic stable angina, unstable angina or rest angina, and Prinzmetal angina. Prinzmetal angina has different mechanism going on. Prinzmetal angina is due to vasospasm, coronary vasospasm. It's a different entity. Whereas these two things, that is stable and unstable angina, is caused due to atherosclerosis. Now, what is angina pectoris? Angina pectoris is a clinical syndrome that presents as paroxysmal recurrent attacks of substernal. Angina pectoris definition I am telling. Angina pectoris is clinical syndrome that presents with paroxysmal, meaning it's not present continuously, it's coming on and off, paroxysmal recurrent attacks of substernal pain or precordial chest discomfort due to transient myocardial ischemia. Which falls short of induction necrosis of will fall short of inducing necrosis of myocardial cell. So what's the textbook is telling to trying to tell is the angina pectoris is the paroxysmal recurrent onset of substernal or precordial discomfort, which is due to transient myocardial ischemia. The myocardial ischemia is not severe enough to cause myocardial infarction. See, the plaque is 70%, 75%, but still, when the demand is increased, like in case of exercise, or when the patient is performing some activities, then the myocardium will fall short and cause this accounts for myocardial ischemia. But this myocardial ischemia is not severe enough, as in kind of thrombosis, where there's partial or complete block. So in thrombosis, it leads on to myocardial necrosis. In angina pectoris, there is block, but it's not severe enough to cause necrosis. So there is only pain. I hope you understood the definition of angina pectoris. Let's continue with the discussion. So we have chronic stable angina. Chronic stable angina. The coronary artery is modified by coronary atherosclerosis when left ventricular hypertrophy and alteration in autonomic nerve function and nothing else like this. Coronary atherosclerosis reduces the lumen of coronary artery. Coronary atherosclerosis has reduced the lumen of coronary artery. It can't increase in perfusion when the demand is increased during exertion or during excitement. This leads to situation where when the demand of the blood flow is increased, like the textbook is telling same thing again and again. So what is chronic stable angina? I already explained 2 times. In chronic stable angina, there is atherosclerosis. So there is blood supply, but during increased demand, the body is unable to cater, leading on for pain, which is substernal. The patient characteristically tell it as mid-sternal squeezing or burning pain, or the pain is from C8 to T1 distribution. The patient can also complain of jaw pain and interscapular pain, etc., etc. This is about angina pectoris, chronic stable angina pathology, how it happens. Now, how to overcome this patient? Please, I already mentioned while mentioning heart failure, please note, if we do ECG in case of chronic stable angina, it will be normal. The baseline ECG of chronic stable angina is normal because there is still some patency in vessel leading on to blood supply in normal conditions. Only if the activity is increased, where the myocardial demand is increased, there will be myocardial ischemia and the symptoms will be provoked and the ECG findings we can see. So if we do stress ECG, we will see abnormality in ECG. And if the stress ECG is positive, go on to do angiography. And if the patient has block on angiography, we can give drugs, or we can do angioplasty then and there itself and prevent the patient from developing acute coronary syndrome. What are the drugs to treat chronic stable angina? The first line drug is nitrates and beta blockers. The nitrates help to dilate the blood vessel, and the beta blockers reduces the heart rate. There, in case of increased demand, the heart rate will not be much increased, so it helps. And also beta blockers will reduce the cardiac remodeling. The second line drugs are calcium channel blockers. The calcium channel blockers will reduce the afterload, and thereby the heart need not pump against more systemic resistance. The third line drug is ranolazine that improves relaxation. I mentioned a golden rule in heart failure that in order to heart to contract adequately, it should first relax adequately. So ranolazine, it improves relaxation and helps in chronic stable angina. We saw all about chronic stable angina idiopathogenesis. There is block due to atherosclerosis. If it comes as solitary 5-mark question. You mentioned about etiopathogenesis of atherosclerosis little more deep, and then we saw workup where baseline ECG is normal, abnormal in case of stress ECG. Then we go on to do angiography, followed by treatment of the patient with first line drugs being nitrates and beta blocker, second line drugs being calcium channel blocker, and third line drug being ranolazine. And next we have unstable angina. What is unstable angina? Give me a minute. The unstable angina is a new onset angina where the patient has pain even at rest. The patient has pain even at rest for more than 20 minutes. This is called as unstable angina or rest angina. Now, what is the cause for unstable angina? The unstable angina is caused due to atherosclerosis leading. Give me a minute. Okay. Sorry for interruption. In unstable angina, the patient has rest pain for more than 20 minutes, which is of new onset. Why the patient has new onset of pain and it's more than 20 minutes even at rest, the patient is developing this because the atherosclerosis may be ruptured and there may be the partial blockage of blood vessel leading on to unstable angina. So this is about unstable angina. Then we have Prince metal angina where there is coronary vasospasm leading on to the angina pectoris. If there is coronary vasospasm leading on to coronary reduced coronary secretion, give nitrates or calcium channel blockers, the patient will be all right. This is about angina pectoris. In angina pectoris, we have chronic stable angina, the unstable or rest angina, and Prince metal angina. The chronic stable angina we discussed nicely. The unstable angina I discussed only in brief because I'm not finding the explanation inside the textbook extensively, and also the other things I should check out in Marrow notes. So please, you can study about unstable angina a little bit. The definition of it, which is rest pain for more than 20 minutes and there is new onset of angina. The Prince metal angina, there is coronary vasospasm where we can manage by giving nitrates and calcium channel blockers. This is about angina pectoris. Next up in the discussion, we have coronary syndrome, acute coronary syndrome. Acute coronary syndrome. I already mentioned acute coronary syndrome is due to the plaque rupture leading on to thrombosis, which may partially or completely occlude the vessel. Depending on the degree of occlusion, we have unstable angina, ST elevation MI, and non-ST elevation MI. Acute coronary syndrome, we have unstable angina, ST elevation MI, and non-ST elevation MI. So, acute coronary syndrome is a spectrum of clinical presentation due to acute myocardial ischemia. We know that the ST elevation MI, majority of which has Q wave on MI. Okay. Non-ST elevation and MI, the ST elevation and non-ST elevation we are classifying based on ECG changes, which are inconsistent with the corresponding pathological changes. The unstable angina, it includes patient with acute coronary syndrome but with normal ECG. Okay. We are classifying this based on ECG findings. The ECG finding is normal in case of unstable angina. There is ST elevation in ST elevation MI, ST depression in non-ST elevation MI. Without elevation of cardiac injury markers and no ST elevation in ECG. Management of unstable angina and NST MI is similar. These two has similar management. The unstable angina and the non-ST elevation MI are due to partial occlusion of blood vessels following thrombosis, and the ST elevation MI is due to complete occlusion of blood vessel due to thrombosis. Plaque is ruptured. Yes. Okay, I hope you understood this. Let's continue to discuss about clinical manifestation of acute coronary syndrome. The symptoms the patient have in acute coronary syndrome are prolonged cardiac pain. We saw in an unstable angina, the patient has rest pain for more than 20 minutes. The myocardial ischemia causing chest discomfort is termed angina pectoris. Thus, the classical manifestation of ischemia is angina. Here, it's usually described as heavy chest pressure or squeezing or burning feeling and difficulty breathing. Angina pectoris, which is prolonged. This discomfort, now we have description of angina pectoris. Let's see that because it's very, very important. It's the heavy pressure, burning sensation, or squeezing sensation, and difficulty in breathing. These three in the chest region. If the patient has squeezing sensation, burning sensation, and heavy pressure in the chest region, retrosternal region, and with associated with breathing discomfort, and the pain radiating to left shoulder, neck, arm, typically builds in intensity. The intensity increases with time, with over a period of few minutes. The pain may begin with exercise or psychological stress, but acute coronary syndrome most commonly occurs without any precipitating factors. Pain may be absent in patients with prior stroke, or age more than 75 years, and diabetes mellitus. Please note, many of the diabetic mellitus patients has autonomic neuropathy. So the autonomic nervous system that is carrying the blood supply to the heart, along with it, the pain sensitive pain receptors are all damaged in case of diabetes mellitus patients. So sadly, they may have silent MI, meaning the patient is having a attack of MI, myocardial infarction, but is not getting it to know, but is not experiencing any symptoms. It is very, very sad because it's associated with poor prognosis, and also the patient may have sudden death due to this. So in case of diabetic mellitus patients who have diabetes in for long duration, please do stress ECG and detect whether there is any abnormality and take the patient for angiography. Okay, this is about clinical manifestation. The other clinical manifestation seen in acute MIR, acute coronary syndrome, anxiety, fear of impending death because the patient is experiencing this severe pain, and nausea, vomiting. And also the patient may have syncope due to reduced blood pumping by heart. So we saw etiopathogenesis of acute coronary syndrome, the plaque rupture leading on to vessel thrombosis. And then we saw angina pectoris definition, the retrosternal pain, which is burning, squeezing, heavy pressure, radiating to left shoulder, neck, arm, which is increasing in intensity with time, associated with breathing discomfort. And due to this, the patient is having anxiety, the fear of impending death, nausea, vomiting, and also the patient may have syncope. This is about the clinical manifestation of acute coronary syndrome. Now, what are the complications associated with acute coronary syndrome? The complications are, it may be due to reduced cardiac contractility due to death of cardiac myocyte due to ischemia. It leads on to stasis of blood inside the ventricle due to reduced contractility. It may lead on to stasis. And we know the blood stasis will lead on to development of thrombus. And this thrombus may dislodge and may have embolic complication. We may have systemic embolism secondary to acute coronary syndrome. So we saw, if the contractility of heart is reduced, there may be blood stasis leading on to thrombus development and systemic embolization, which may lead on to renal infarction, limb infarction, stroke, etc. Then we have obviously reduced stroke cardiac output, which reduces systemic perfusion. And due to secondary to necrosis of ventricular wall, the death of due to necrosis, if the myocardial infarction is occurring near the sites where the cardiac pacemaker like SA node is present, there may be conduction abnormality leading on for arrhythmia. Let me break down for you. Okay, 1 minute, I will explain here. Yes. See here, if you have inferior wall level, the explanation is very extensive. We have on ECG we can detect the site and all, which we'll see next year. We leave it. If the patient has acute coronary syndrome, the necrosis of myocardium adjacent to any conduction system, that is bundle of his SA node and AV node and all, obviously there will be involvement of these structures and it may lead on to arrhythmia. Just remember this point. Other points we'll discuss afterwards. The transmural necrosis of interventricular septum, here in the necrosis, the transmural necrosis of interventricular septum may lead on to acquired ventricular septal defect. Also, due to irritability of viable tissue adjacent to infarct area, there may be myocardial electrical instability, which again lead on to arrhythmia due to increased irritability of normal tissue. These are the few main complications which is associated with this. There may be also the rupture of the necrosed tissue, cardiac rupture. The patient may also have necrosis. This necrosed tissue may irritate the pericardium and cause pericarditis. And secondarily, this may lead on to cardiac tamponade. Due to reduced systemic perfusion, we may have secondary effects like acute renal failure associated with acidemia and all. And also all these things, myocardial damage. Okay, I'll summarize the complications of acute coronary syndrome. Complications are due to two things: reduced contractility and necrosis of the tissue. The reduced contractility is secondary to necrosis of the tissue. The necrosis of coronary myocardium will lead on to arrhythmia if it's adjacent to any conduction system, and also due to irritability of normal tissue surrounding the necrosed tissue, we see arrhythmia. The necrosis, transmural necrosis of interventricular system will lead on to acquired ventricular septal defect. There may be rupture of cardiac myocardium. The necrosed tissue may rupture, cardiac rupture. The necrosed tissue may irritate the pericardium and cause pericarditis, and pericarditis may secondarily lead on to cardiac tamponade development. We saw complications of acute coronary syndrome. Associated with it, we have cardiogenic shock, embolism, and all. We can also have secondary to necrosis. We can also have ventricular aneurysm. I think if we mention this much for our RGHS exams, we can manage. Now we have investigations and treatment. The investigation and treatment of acute coronary syndrome is very extensive and it is practically very important for all of us. What are the investigations that we do in acute coronary syndrome? In case of STA, first we will do ECG, and always we'll look for reciprocal changes in case of ECG because it mimics other disease. How we tell for sure that this ECG changes is due to MI is by looking on for reciprocal changes, which we will discuss afterwards in internship. In ST elevation MI, there may be T wave inversion or ST elevation. So the site of lesion, we can also see whether it is left coronary artery or right coronary artery based on specific ECG changes. Non-ST elevation MI will have subendocardial ischemia. There is peaking of T wave, the ST depression. So we will mention in ST elevation and MI, there is ST elevation with convexity upwards. And also there is T wave inversion associated with this. Also in non-ST elevation and MI, there is ST elevation, ST depression, and peaking of T wave. This much we will mention in ECG. After doing ECG, after confirming this, we'll take up the patient to do angiography. The most preferred is coronary angiography by injecting dye, or we can also do CT angiography or MR angiography. Following that, we can do treatment angioplasty. So these are the investigations that we do: ECG, coronary angiography, and also we can also do echo. This is about investigation done in case of acute coronary syndrome. Now, how to treat the patient presenting with acute coronary syndrome? The treatment is extensive. We have medical thrombolysis. So before that, I will discuss what we will do in treatment. We saw in pathophysiology that there is thrombosis. So this thrombosis can be dealt in two ways. We can medically give antithrombotic drugs and cause this thrombosis to resolve, and we can resume the function of myocardium. And also we can also do, after doing angiography, we can do balloon angioplasty, place the stent and treat the patient. If the patient presents with pain, the first medical contact will do ECG. The first medical contact is the person, medical or paramedical, who knows how to read ECG and know how to do defibrillation, how to use defibrillator. First, the patient will have pain. He will go to nearest center where he meets with first medical contact. And if the patient has the facility, the time between first medical contact and diagnosis should be less than 10 minutes. Before that, the time is muzzle in case of ST elevation MI. Since there is total occlusion, if the patient presents less than 6 hours and we do successfully perfuse the myocardium within 6 hours of injury, we can save the myocardium. So we can reduce the possibility of irreversible injury to the myocardium. And if the patient has presented more than 6 hours, it means that there's extensive injury to myocardium. And also the patient will have electrical and mechanical complications and all. Okay. The patients will have pain. He will meet first medical contact. The first medical contact we should diagnose the condition within 10 minutes, and then in first 24 hours we should see the first medical contact should uh, should see that whether he have any PCI capable centers nearby or not. PCI capable center means percutaneous coronary angioplasty centers. The centers we can do percutaneous coronary angioplasty. Whether the center is available or not, you should check. If it's available, send the patient, and there should be cross wiring. That is sending of the cardiology should be perfusing by the stent within 60 minutes after the diagnosis. So if it's not possible to shift the patient to this PCI center, PCI capable center within 120 minutes after the diagnosis, we should thrombolize the patient. How to thrombolize the patient? We can give bolus tenecteplase and retaplase. Tenecteplase 0.5 mg per kg, 10 international units, 30 minutes apart, 2 doses. And then we can give enoxaparin 30 mg bolus, 1 mg per kg subcutaneous BD. After that, we'll shift the patient for thrombolysis within 60 to 90 minutes. So what I mentioned here is, first the patient will develop pain. After that, he meets the first medical contact. The first medical contact should diagnose the patient within 10 minutes. And he will think that whether the PCI capable center is available nearby or not. If the patient can be shifted to PCI capable center within 120 minutes, we'll shift the patient here, and the wire crossing should be done within 60 minutes. And then less than 120 minutes. Okay. If it is not possible, we'll thrombolize the patient by giving tenecteplase 0.5 mg per kg or retaplase IV bolus. And then we will think of shifting the patient to PCI capable center. Now, after 60 to 90 minutes, we'll check whether our medical thrombolysis is worked or not. What is successful thrombolysis? If there is 70% ST resolution, we'll call successful pharmacoinvasive thrombolysis. And we should do percutaneous angioplasty within 2 to 24 hours in that case. If the medical thrombolysis is unsuccessful, we should do rescue PCI ASAP as an emergency. This is about the treatment of ST elevation MI. The management of ST elevation MI. So we discussed about acute coronary syndrome, the 3 types: unstable angina, stable, chronic unstable angina, the ST elevation MI and ST depression MI. We saw the investigations. Etiopathogenesis we saw investigations. ECG changes. ECG changes are normal in case of chronic stable angina. And then we saw the treatment of non-ST elevation MI. Now, what is the treatment of non-ST elevation MI? The guidelines is we should do PCI within 24 hours or within 2 hours in high risk cases. Okay, in non-ST elevation MI, we are doing PCI, that's angioplasty, balloon angioplasty, percutaneous coronary balloon angioplasty within 24 hours usually. If the patient has high risk, we should do it within 2 hours. There is no role of thrombolysis in case of non-ST elevation MI. Please note this point. There is no role of thrombolysis in case of non-ST elevation MI. Okay, in case of chronic stable angina, we already discussed how to treat. The non-ST elevation MI, how to treat? We'll do percutaneous coronary angioplasty within 24 hours. In high-risk cases, within 2 hours. There's no role for thrombolysis, pharmacological intervention. I hope this class is useful and all of you has understood acute coronary syndrome. Let's see